need data to be able to make policies that are relevant and to actually understand what are the causes of cancer in sub-Saharan Africa so that we can be able to control it.
It's part of our role in public health, if you like, to improve the lot of cancer sufferers worldwide, improve cancer control, and cancer registration is a vital part of that. Cancer registries are there to provide information on the incidence of cancer, the stage of disease at which cancer occurs, and the outcome, the survival from cancer. And those are very important statistics in planning and developing cancer control programs. They're very fundamental.
In the last 10 years or so, we developed a global initiative for cancer registry development, or the GICR, with the African Cancer Registry Network. We now have 3 collaborating centres, which shows the expertise that we have in the region.
So one collaborating centre in Nairobi in Kenya will be responsible for education and training in cancer registration methods and use. The second centre will be in Johannesburg in South Africa. That's going to be concerned with linking clinical and screening data to cancer registry data, and also with registration of childhood cancer. And the third centre is in Abidjan in Côte d'Ivoire. That's based in the Abidjan Cancer Registry, and they will be responsible for technical support to the registries in French-speaking Africa, in West and Central Africa.
Data is a powerful tool. Without data, we are not able to make informed decisions. The cancer registries in sub-Saharan Africa, there's so much need for training, for capacity building, for support even in their collection of data, interpreting that data, and a lot of the technical challenges that come while doing this work. So our role as the IAC Collaborating Center is to build capacity in sub-Saharan Africa so that the cancer registries are able to generate quality data that can be used to inform cancer control initiatives in their respective countries. We can inform our governments to put in place policies, interventions that can control some of these particular diseases. So that is my motivation.
We work as a hub, a regional hub, and in training of cancer registries, in training for the using of CanReg 5. Sometimes we do some consultancy, some monitoring in another registry in a friendship country in Sub-Saharan Africa.
Donc, tout dernièrement, en mars, nous avons eu même une formation en ligne sur la stratification des cancers. Ça nous permettra, on veut à partir de ce projet-là, amener les pays aussi à comprendre l'importance du registre dans la stratégie de santé publique, surtout pour l'élimination des cancers, notamment du cancer du col de l'utérus et les autres cancers. Donc à partir de ce projet-là, pouvoir avoir une bonne collaboration des ministères, des gouvernements pour le support des différents registres.
So our 2 primary roles as the collaborating center in sub-Saharan Africa for childhood cancer and monitoring of cervical cancer elimination through linkage of cancer registries and screening registers. In sub-Saharan Africa, the burden of infectious diseases is very high, and because of that, non-communicable diseases like cancer are trying to compete for a piece of the health budget, and in most countries you find that cancer is sidelined. But when we become an organized collaborating center, we are giving each other strategies on how to approach stakeholders, and we're sharing experiences. It strengthened cancer surveillance within the whole region. So I am excited to be part of that team that is going to change that and provide accurate data and explore risk factors for cancers in Africa so that our policies are relevant and they actually achieve what we want them to achieve.
Welcome everybody. My name is Mariana Tiabet. I'm the CEO of Vital Strategies, and it was so great to hear from so many of our colleagues across the African continent, and with whom we work with to support cancer registries. For those in the room, welcome. We'll really try to make this a conversation, because I know you're here because you care about cancer, and you want to learn more about cancer registries, and I'm sure you have experience and things to bring to the conversation, so welcome. We also have about over 200 people who are listening in online. So hello everybody, good morning, good evening, wherever you are. And we're also excited for you to join us. I think where I want to start is to remind everybody why we're here. And I think it's probably safe to say that we're here because all of us want to help reduce preventable suffering from cancer. 1 in 4 deaths globally is from cancer. 70% of them are in low and middle income countries, but only 6% of the populations in those regions are covered by cancer registries. And so not only are we blind in this work, we are also working in the dark. And I think what we want to do is both, shed light on the situation through cancer registries, but also have cancer registries inform, how we do this work. If there's one thing you should know, I'll tell you 3 things you should know about Vital Strategies. 1, we believe in the data. We are a data-first organization. Data to understand the issues, data to actually connect across the issues, data to solve for the problems, but data to also hold ourselves accountable. I think the second thing you should know about us is that we don't believe in going it alone. And so we're just really excited we're able to co-host this session with our friends and colleagues from the Union for International Cancer Control. So thank you, Harry. Thank you. And I think from my perspective, there's so many reasons why we shouldn't be going it alone, but I think one of our colleagues mentioned a very real one. There is a fight for resources. Governments have a very tough time figuring out how they should spend their precious resources because the need is just too great. And so where we can come together to identify intersections, capture synergies, and multiply our impact by working together, we should be doing everything we can to make that happen. And then the third thing is I do believe we are in a special moment in time, at least in my professional lifetime, where there's an opportunity for us to change how business as usual is done in global health. We know that there have been significant funding cuts that have forced people to think about if the ways that they have been working are the right ways. It's also created an opportunity for us to reimagine our work, and I would also say reform how we work and think through how can we create environments for governments to sit in the driver's seat. And I do think cancer registries epitomize, one of these approaches by being able to create situations where countries own their data. Countries understand their data, and countries are using their data to make the best decisions for their people. And I do think that we should take advantage of this opportunity to really show the broader global health community that when we come together, we can, in fact, support government-led, country-owned prioritization and accountability for these issues. So all that being said, I won't waste any more time. I would love to invite introductory remarks from our colleagues and co-hosts. So first I'd like to ask Dr. Larco Cieza. I hope I'm getting it right. She's the head of management of NCDs, and I've been told nobody knows what that means, but I think all of you know what that means here in the room. I hope you do. If not, you're probably in the wrong session if you don't know what NCDs mean. But the Department of NCDs and Mental Health at the World Health Organization. And in this role, she provides strategic leadership, management supervision, and overall direction to WHO's work on the management of NCDs and integrated service delivery. So welcome, Prof.
Yeah, great. Thank you, Marianne. And let me say why I'm here, because actually it was Dr. Tedros who was invited to this session, and when it was clear that he would not be here because he would need to go to our regional committee in the Southeast Asia, then I was requested to be here. So when you hear me to speak, you really hear really the institution and WHO and the voice also that go across the organization, from all of us who work more technically, but also to the leadership of the organization. And with that, good morning, actually, good afternoon, and perhaps good evening to some of you. And I'm really very thankful to Vital Strategies and to the Union of International Cancer Control for organizing this session. And we are really extremely happy to be here as WHO, and we are also happy to be here with our sister organization, IAC. And look, the main message of this session is, of course, that cancer surveillance with population-based registers is a foundation, the main foundation of effective cancer control. Actually, when we encourage countries, and we have been discussing it in several sessions during these days, to develop national cancer control plans, then we encourage them to implement, but we know that in reality, without data is, actually Marianne said, going in the dark. I wrote here down, driving through the night without headlights, or with the headlights off. So that is the situation. So high quality population-based cancer register fill that gap, and it is fundamental. And look, all of you know that WHO has launched 3 cancer initiatives. This, on cervical cancer, on breast cancer, on childhood cancer, and each of them has the objective to support governments to tackle these different parts of the cancer challenging. And we use this initiative also as entry point for strengthening cancer control in countries as a whole. And probably all of you know that we have targets, especially for all of them, but you know also probably especially the target on cervical cancer, the 90-70-90 targets, and also the target in the breast cancer initiative to reduce breast cancer mortality by 2.5% every year. And again, this moving toward achieving these targets without the appropriate data, it would be, again, like walking in the dark. So for that reason, also for implementing from a WHO perspective, for implementing these global initiatives in cancer, population-based cancer register are absolutely fundamental. And it is also good news, I think, for all of us that the political declaration that we expect to be endorsed in the next couple of days contains also the 3 initiatives and the achievement of those targets. And a point that I would like to make is that just as importantly as using this data from cancer register, whether it is for national cancer control plans or moving towards targets, cancer registers also allow to establish a link between outcomes with health financing data or health financing mechanisms. It is important also to use that data from cancer register for a link, to use and link it to the data from universal health coverage. For example, in how many countries that health benefit packages for universal health coverage include coverage also for cancer services. And we know, for example, that in a report that WHO and the World Bank launched in 2023, that most low and middle income countries have not included cancer services in their health benefit packages. But what we can do with the data of cancer registers is to know what is the impact of that lack, or what is also the impact when countries move forward towards universal health coverage, including cancer services as part of it. So data from registers give governments the data they need to invest better. And actually, that is also the reason why this conversation is so important today. And also, as Marianne said, it's not only important, it's also extremely timely, because now more than ever, as investments in health and development face cuts, is absolutely essential that partners come together to discuss strengths, to identify needs, needed improvements, and also to build a stronger case for such critical area of health and development as population-based cancer registers. So thank you again to Vital Strategies and to UICC for organizing this session, and I look forward really to the discussions. I will stay here throughout the session.
Thank you so much. And I think you'll start to see how bringing together all of the different actors, in the cancer space, not just the prevention folks, the care and treatment folks, but the data folks, the providers, the patients, and I think we all have to have this conversation about what the data means and can mean. So with that being said, I'd love to introduce our representation for our co-host, Ulrika Hagstrom, who is the president of the Union for International Cancer Control, also known as UICC. She is also Secretary General of the Swedish Cancer Society, board member of the Nordic Cancer Union, and a member of the Swedish government's Life Science Advisory Group. Her background is also in finance, crisis management, and leading large and complex organizations in times of change. So you are in the right place at the right time and fully committed to the fight against cancer. So would love for you to share your reflections and some of the
Thank you, and I think we're going to repeat a bit something what we've heard from other participants and also in the excellent video that we saw. But we all know that by 2050 we expect to see annually 35 million people being diagnosed with cancer, and the fastest increase will hit low and middle income countries. And there's an urgent need to scale up prevention, treatment and care, yet too many countries lack the data to respond accordingly. In cancer registries, they give us crucial insights: who's getting cancer, at what stage, and what outcomes look like. And by capturing additional information like biomarkers, treatments received, socioeconomic factors, disease recurrence, and patient-reported outcomes, not that common in all cancer registries so far, we get an even deeper understanding of the disease and how interventions are actually working. Because I think that's the main thing here. And as you heard, I'm from one of the Nordic countries in Sweden. We have one of the oldest population-based cancer registries in the Nordic countries, more than 60 years. And we know that most of the high-quality cancer registries exist in high-income countries. And as Marianne said, only 6% of the population in low-income settings are included in cancer registries, which is a real disaster. And with the information we get from cancer registries, we can identify the most common cancer types and populations at highest risk, and we can allocate resources where they are most needed. And we can design targeted prevention and treatment strategies and evaluate whether interventions are working or not. There's a vast gap in the understanding of the true cancer burden in the world because so many countries don't have this population-based cancer registries. The statistics we do have often underestimate incidence, mortality and survival, and they can give a false sense of reality, showing misleading trends and ultimately lead to a weak response to cancer and a misuse of resources. So without data, countries have to rely on estimates that may not really reflect the local realities, and that can lead to misinformed policies and missed opportunities. And I think we really need to reflect on that. So it goes without saying, just to echo what you said, we can't tackle the global cancer burden if we're flying blind. And I think we're doing that to an extent. But it's not just about collecting data. We need to connect the dots and integrate data from various sources, hospital registries, electronic medical records, death registries, and population-based cancer registries. We get a far more complete picture of the cancer landscape. And by connecting the dots across the cancer continuum, we can move from fragmented efforts to coordinated, data-driven approach, which is really the core of vital strategies that addresses cancer comprehensively. At the same time, advances in medical knowledge and precision medicine mean that we need more and more data. And this is a real challenge for cancer registries, even in high-income countries, but especially where resources are limited. And it shows why close collaboration between clinics and cancer registries is so important. I'm representing UICC here today, and we recently conducted a global survey looking at how population-based cancer registries collect data worldwide. And the results show that registries are committed to improving data collection and expanding their work, but they often face significant barriers. And of course, the obvious barrier, one of the obvious barriers is the funding situation. But other examples of barriers include human resource limitations, training and education, which is really important, data protection, privacy regulations issues, and with accessing data sources, as well as technological and methodological challenges. And this is also something we raised when we organized. You mentioned the National Cancer Control Plans and the importance of data in National Cancer Control Plans. And in May this year, we organized the first Cancer Planners Forum, inviting 40+ countries and their experts in cancer planning. And one of the focus areas was really in cancer registries and how to work with data and connect the dots. It was a key topic and something that we continue to work with them on. So it's encouraging that most registries want to innovate, they want to use new tools, collect data faster, improve quality, expand the types of data together, and strengthening the collaboration. But for this progress, we need real investment. But it's not just about money, it's about investment in time, training, human resources. But I think we can make this work. This is just some reflections to start the conversation.
Thank you so much. A lot of sweat equity I know folks are putting into this space. So thank you. We'd love to actually start the panel now and introduce everybody to Dr. Adam Kalpadi. He leads Vital Strategies public health programs that comprises of teams working in dozens of countries worldwide to strengthen their public health systems, addressing leading causes of death, illness, and injury. He's a globally recognized expert in public health with more than 20 years of experience in epidemiology, emergency response, and policy. And one of the major global initiatives that he leads at Vital Strategies is our Data for Health partnership with Bloomberg Philanthropies. And this supports countries across the globe in improving critical elements of their data infrastructure, including civil registration, vital statistics, and cancer registries. So over to you, Adam.
Thanks very much. Hello, everyone. We're going to get into our panel discussion with our distinguished guests. I'll just offer a couple of framing remarks before we start. As Marianne has mentioned, we at Vital Strategies work always through a partnership model. We're very proud and pleased to partner with the folks in this room, organizations like IARC, like the African Cancer Registry Network, and of course with the governments that we work with. And all of our cancer registry work is in tight partnership and indeed embedded within government institutions. It is foundational, and we like to talk about foundational, next generation foundational data sources for public health. As Ulrika said, cancer registries are the core of cancer surveillance, and there are opportunities to take and to make these foundational data sources truly robust, using new technologies, new approaches, and that's really the kind of work in which we're engaged. And the point that Marianne made about data sovereignty, the importance of government-owned, government-led data that is able to reflect the granularity of the facts on the ground, different populations, inequities in incidence, in survival, in stage diagnosis. And so that data sovereignty component is at the core of our work as well. And last, the connection between data collection and data use for policy making, and those principles, and which really doesn't just happen, as I'm sure we all know, but requires intentionality and effort. We work in over a dozen countries on cancer registries, as Marianne said, as part of the Bloomberg Philanthropies Data for Health initiative, and with not just the national governments, but with regional agencies as well, like the 3 collaborating centers you saw in the video. Our work touches on elements of governance, including the role of national ministries of health in overseeing and coordinating registries, complementing hospital-based registries at the institutional level with population-based registries overseen by government. And the linkage of multiple registries in a country together to form a organized system. SOPs, training, human capacity development, reporting, all of these elements. And just one dimension of the detail I'll mention, the link between some of these foundational data sets, cancer registries, civil registration, and vital statistics. The survival function, the survival measurement function of registries, it can be enabled with tight connections to the CRVS systems. And so that's an example of the kind of linkages that we can look to as CRVS improves and cancer registries improve. And then last, the kind of complementing country level work with global goods, global resource production, and that's again in deep partnership with our friends at IARC. Training programs, technology tools, and other areas of global resource. So with that framing, I'm going to turn it over to our colleagues. I'll say one more thing, sorry. There's several of the folks in the video and colleagues of ours just this past weekend and today are in Abuja at the African Cancer Registry annual meeting. That's in partnership with the Network for Oncologic Research in Africa. And the themes that we're hearing from our colleagues there are the themes we're talking about here. The linkages between registries and the cancer control, the service sector. The role of these newly established collaborating centers to support registries across the region. New registries coming online all the time, just in the last few months in Chad and Cape Verde and in Angola. So it's a nice parallelism that we're here talking about this here, and our colleagues are there as well. So with that, our distinguished panelists, we'll start with Dr. Marian Piñeros, a Colombian scientist working at the Cancer Surveillance Branch at the International Agency for Research on Cancer, IARC. Since 2015, she's involved with the Global Initiative of Cancer Registry Development, GICR, the global organizer of all of this cancer registry work. and she contributes to descriptive epi studies and in the production, dissemination, and use of information for cancer control. Why don't I turn it over to you, and I'll introduce our three panelists one by one as we go.
Okay. Thank you, Adam, and good afternoon for all of you present here, and good morning or afternoon for all of those that are joining us online. You all know that for IARC, cancer data is one of the landmarks activities. For many, many years, we have the responsibility to give data to our countries, to WHO countries, and we have done this for many, many years. But then we have done this mainly through estimated data. And estimated data are very good, but in many cases they are not enough. And they give a national picture, and what is behind those data that we use to construct this is really the data that we call it, they are powered by population-based cancer registries. So these are our main sources, together with mortality. And in many cases, we don't have enough data to do the estimates, so we use different models, and we need to use from neighboring countries. I think that never before we saw so much interest in cancer registration as we see now, and we are very happy that we have so many institutions and organizations telling us about the importance of data. We were very alone, I think, in this first part, like 20 years ago, working with cancer registries, and we see more and more interest. And for many people, I really want to highlight, have a look and look at what is observed data versus estimates. Because observed data will give us very interesting pictures. The risk of cancer in one population is different. Even in the country, it is different. We have regions with very different risks of cancer. Let's take the case of cervical cancer. We have a cervical cancer initiative. We need the data to follow it up, but cervical cancer in some countries is not problem number one. But in that country, maybe there is a region that really needs these data or needs to act upon. I probably don't want to enter again into the rationale and all the use, because you have already highlighted very well the use for planning, the use to set priorities, the use to follow up and look how the outcomes of our programs are. But something that I think in the video was mentioned and that IARC does very much is also research. And we need this research for cancer control also. Let's say esophagus cancer in African countries, where we have seen that this is linked to the way of cooking and to this cooking smoke that is the risk factor. So with the gaps that we have in cancer information 10 years ago, and like we saw in the video, IARC and many of the partners started GICR, the Global Initiative for Cancer Registry Development. And I think it's a global program which looks forward to work with the local basis, with regional, and through a global coordination. We have set up 6 regional hubs. One of those was the hub that we were seeing in the video. All hubs have a slightly different way of operating, but we all do more or less the same activities. So we do training, support to registries, networking, and showing governments the need and the use of the importance of that. But we are very few. We are really a small team. So we need partners, but we also have set up our collaborating centers of expertise. And the video that you saw was for the African hub. But we have other 5, where we also have centers of expertise. And we have been able to roll up this and to be a little bit more efficient, thanks that we have also what we call our GICR Next trainers. We have set up a group of trainers in different aspects. They are experts already. We just brought them and have some master classes. So we have also in the field people that are voluntarily, they are experts and they are helping us in all this duty. So I would say that, with our GICR, we are covering more or less 100, we target 150 countries in all these continents, low and middle income countries, and we would say more or less 85% of the population, because Asia alone takes 50% of the population. That is what I really wanted to highlight in this first part, and let you know a little bit more about the GICR, and then we will talk a little bit.
We're going to get into a conversation with our panelists. I'll just introduce our next two panelists. Ask you maybe just for some short remarks, and then we'll get into the conversation. Lillian Genga is Program Officer at the Kenyan Ministry of Health National Cancer Control Program and the Pillar Lead for Prevention and Early Detection. She has extensive experience in cancer prevention, detection, policy implementation, and capacity building for health workers at the national and county levels. We're extremely honored to have your presence here and to talk about the connection between the data and the work of cancer prevention and control. So perhaps a short few remarks.
Thank you, Adam. Good evening. I think it's evening. Good morning. Those who are online. Yes. The talks that have been going around kind of are the talks which are actually in my head. It's like they're speaking out for me. But just to repeat probably what they have said, and I take data to be very, very important. Since using data gives you a lot of information, you cannot know if you don't use data. I basically narrow it down to two cancers that are very prevalent in my country. That is women cancers, cervical cancer and breast cancer. You find that cervical cancer is leading in mortality and breast cancer is leading in incidence. So for us to get this data, we have to do the screening and find out if what is happening. Despite all this, still the uptake is not, it is if data is forming us that the uptake is not well. So it's can say that it's helping us in decision making and also giving us a way that we are seeing the trends of how these cancers are doing in the country. Are we making it or not making it? So it's a lot of information that we're getting. Are we following the WHO targets of cervical cancer elimination and breast cancer initiative? At least those two cancers we have the targets, and the childhood cancers. But basically, if I talk of the women cancers, they have the targets that we are following, that is the 90-70-90 and 60-60-80 targets. So it's really informing us on what to do, the decision to make, and we find that this data is informing us whether we are supposed to do training to health workers, how to do screening, how to vaccinate girls, and which particular areas, which counties in my country. It is divided in counties. We have 47 counties. So which counties are we supposed to go to, which are vulnerable, where we find that maybe cancer is more than other counties. So data information actually speaks a lot in guiding us when we are also doing a distribution of resources, so that even hard to reach areas can also get some resources and they're supported. Also, it's also helping us to know, especially if you go to the hard to reach areas where you have regions where I can say hard to reach, like there are regions which are they're not close to the city, they're away from the city, and their cultures are also different. They just have their culture. So this data is informing us how they are performing and also what ways can we go about it. And in this case now, it has informed us that we can move from screening of cervical cancer from using visual inspection with acetic acid and to the HPV DNA test, where we do self-sampling so that we can reach these women who would not want to be screened because of their culture. Their culture doesn't allow them to be seen naked by the doctor. So when you give them the self-sampling, they can take their own sample. And also we teach them self-breast examination so that they can do their own self-breast examination. Again, this data has informed us about vaccination because also there's vaccination hesitancy. And in this case, we've been doing the 2 doses, vaccinating with the 2 doses 6 months apart. Now we are moving into 1 single dose. So data has informed us in this. So can go on and on and on. Yes, so I think it is data is informing us on much on those cancers. Thank you.
And our third panelist, Dr. Chu Kia Lin, my colleague at Vital Strategies, serves as Senior Technical Advisor for the Asia Pacific region for our work on cancer registries, where he leads efforts to strengthen PVCRs across the region and currently supporting ministries of health in Cambodia, Sri Lanka, and Vietnam. Over to you, Christopher.
Thank you, Tim, and thank you everyone for the attendance. And I'd like to say hi to everyone on the online. So I'm Dr. Lin. So when we talk about cancer, we talk about all the members, all the deaths. But as a medical doctor who works in a hospital, the way I see when I go to work every day is the crowded wards, like hundreds of people waiting, sometimes people crying, and people losing slowly their livelihoods and money. So it's been a tragedy at the personal level for most families. It's also a suffering for the doctors and nurses because we sometimes cannot give the treatment they have. We have machines are sometimes broken and the waiting lists are long. So cancer is a huge, huge suffering for the families, caretakers, and the medical personnel. So I'm happy that for the Vital Strategies, we have been working in Asia Pacific region and also in Africa. Not only the project countries we are working in, we are also providing some grants to the different countries depending on their proposals that can reduce the burden of suffering from cancer. So in the countries I work in Asia, we talk with the government. So basically it's we really seek the commitment from the government because we don't want to go with a bag of money and say that, hey, we bring the money, you have to do this. This is definitely not the way we work. So what we seek is a very close partnership, open, honest talk to talk with the ministries of health, director generals, the national cancer control programs. We have the expertise. We can be the bridge with all the international standards and experts, and we really want to adapt to the context and what is the commitment from the government. And that is the first thing we really seek. And in most countries, this model works very well because the government are now understanding and realizing the importance of cancer. And they really have low resources. So for example, when we talk about the global burden of diseases or the estimate, you have some numbers. But even in the country, you may have different age groups have different numbers, different people with different occupations, we have different risk factors that have affects different outcomes. And also, even at the hospitals, many patients, they don't die in the hospital, they go back home. So even as a doctor or nurse, I don't know if my patient is dying or not, many of the times, because we just simply lost contact. So these are the things why the strategy is trying to support at the individual level, at the hospital level, at the laboratories level, at the civil registration and vital statistics, data collection and data linkage level, at the ministry level, at the provincial, at the national level. So these are the scope of what we work daily with through the clinicians, through the public health departments, national cancer control programs, like community data registrars and all this. And we hear that the governments, they have, let's say, some limited money. So there's a lot of things. Okay, should we do breast cancer screening? Should we do cancer vaccination, provide cancer screening? And money is very limited. And the community workers, they have so much work to do, like maternal health, nutrition, all this. So even for like breast cancer screening, like do we do only like soft breast? Like where do we do the fine aspiration? Where do we do the X-rays for the breast? And what level of hospital should provide these facilities? These questions are often not answerable without exact high-definition data at the population-based cancer registry. It cannot be get from the data from the hospital-based cancer registry, because you really need a clear, high-quality, complete picture of the population to make these high-resolution positizations and assessment patients. Thank you.
Thank you so much, Lynn. There's lots to unpack here, but I wanted to start by saying, Lillian, when you mentioned cervical cancer had the highest mortality in your country, I was surprised. I was surprised because we know that cervical cancer can be prevented. I was surprised because there are many ways to screen for cervical cancer. And it's actually one of the cancers that is responsive to therapy if caught early stages. And when you said that, I quickly looked at a paper that the Rwandan government, in partnership with Vital Strategies, developed, looking at the survival analysis, for all of the adult cancers. They also did it for childhood cancers, but adult cancers in their country, based on the data from the cancer registries. And for cervical cancer, we have only 32% of cervical cancers in Rwanda were diagnosed stage 3 and 4. And the 5-year survival in Rwanda is 55%. And so I think when you have that kind of granularity of data, and you're able to compare not just across countries, but also within countries, I think you start to see where you can target interventions, because it's not going to be one size fits all. But with all of that, Lillian, I'd love for you to share, just some opportunities that the data has created, perhaps some success stories in terms of how it has been used to move the needle on patient outcomes and targets for your national plan.
Yeah, thank you, Maria. Yes, we have used data to inform training of health workers on cervical cancer. Mainly the health workers, even themselves, you find they don't know the cause of cervical cancer. When they're taking trainings, they're going through their trainings, it's just a mention, and just like cancers, but it's not like they go into details of one particular cancer. So when one particular cancer comes rampant, like preventable cancer, like cervical cancer, we find that they don't have a proper knowledge on it. So data has informed this by seeing the trend of mortality of cervical cancer, and we have trained at least around the country. We have trained the 47 counties. We've trained health workers. Not all of them, but at least all the counties. We have trained some health workers who are now able to do screening, and also enough we have the treatment devices of treating precancer lesions before they just get into cancer. And we have provided this to the counties, all the 47 counties at least, there are some devices for treatment of cervical cancer lesions. So I can say those are some success that we have got on data, because initially we started with 25 counties. These 25 counties, we trained the healthcare workers as the nurses, clinical officers, and medical officers, gynecologists on NIP and colposcopy. Then we still remain with 22 counties. So we had to look for funds first, getting hard to cover the 22 counties. So the 22 counties, currently I can say we have not trained them on NIP and colposcopy and give them the devices, but 25 counties are completely trained and covered with NIP and colposcopy and thermal ablation machines. And currently I can say that WHO also is supporting the country in not only cervical cancer, but women cancer, as I said, and NCDs, whereby a woman is screened. You don't just screen the breast and cervix and let this woman go home when their blood sugar is high, when their blood pressure is high, so and mental health. So WHO has brought in a project called WICS, Women Integrated Cancers, which we are doing in 2 counties in Kenya, and just as a pilot, it will be scaled up after that. And also the Global Alliance of Women Health are also doing a project in 2 counties as a pilot again on breast and cervical cancer. So all these have been informed by data. These counties were picked according to the data, the trend of the disease, how much is it in those counties. So that is how we pick the counties using the data. Yes.
Thank you so much, and it's so great to see all of the work that's happening and that's changing and saving lives. Marion, I'd love to come to you because you talked about how the data that we're surfacing in the registries allows us to ask additional research questions, so where we see unexpected trends, looking for causes or etiology. How is cancer registry data, or is cancer registry data also used to support clinical trials, for example, because I think we know that what may work in certain populations may not work in others. And one of the other conversations that is happening right now is how do we increase, then you talked about oftentimes there's no treatment. How do we increase access to treatment? And so just wondering if you can speak a little bit about does cancer registry data support, some of these, answering some of these questions about what would be the appropriate treatments in these countries and having own data, country level data inform that?
Well, thank you for the question. So the granularity of information and of data that we have in a population-based cancer registry is very limited in terms of really capturing all of the types of cancer and having hopefully stage information. However, more and more what we see is that, and it was shown also in the research that Ulrika just mentioned, is that governments and people are asking for more data. So the treatment data are difficult to obtain in population-based registries. We obtain them more in hospital-based registries. But many of the, especially of the European countries, are doing what we call high-resolution studies. And high-resolution studies based with the data, or starting from the data of population-based cancer registries, go into much more depth to try to understand, for example, more than clinical trials, like what has been the effect, for example, of clinical guidelines, whether the population as such in a given city or in a given country is following some guidelines. So it's more in that sense than in the sense of clinical trials.
Thank you so much. And so you started to talk about some of the innovations that's happening in this space, and talked about the connectivity or the difference with hospital-based registries. Adam, I'd actually love for you to talk a little bit about how are we integrating data, across all of these multiple different sources, and through that type of innovative plumbing. Like, at the end of the day, we're plumbing. And how is that, moving us forward around cancer goals?
I mentioned one example of it, the survival analysis that takes advantage of linkages between civil registration systems and cancer registries. And that information goes both ways. Cancer registries may contain information on mortality that is previously unknown to the civil registration system, and can support it in that direction. And of course, information on mortality is used in the registries to measure survival. And so that's one example of that plumbing, the CRBS to CR linkage. Another one another example is in the initial surveillance of incident cases of cancer. That's one I would cite colleagues in the Rwanda Biomedical Center developed a electronic data collection tool for cancer registrars to use, leveraging the DHIS2 health information system. So this is an example of new technology creating a pathway for cancer registration that was previously done on paper. And that tool is now not pioneered in Rwanda and is now being disseminated around the world with a lot of uptake from registries in different regions as well. So those are some of the pipelines, I would say, that are bringing, as I said before, sort of this foundational data system into the next generation.
So to continue the metaphor, Lynn, so you're working in the bowels of the system, and Adam started to talk about plumbing, connecting the pipes. None of that's possible, I think, without strong relationships with government, and also being guided by government. Would love for you to share, some of those experiences in terms of working with the different governments we partner with, and talking through, how are we introducing innovations, into the space? What are some of the things that are priorities for them, that you hear about, and how we respond?
For the Registries program, we work in different country contexts. So, and also at different levels of maturity in terms of like epidemiology, cancer data collection, and like cancer surveillance system. So each country is very unique. So whenever we talk with a country, we really first have to understand what is the situation. So we usually get this information from our existing partners, and like particularly guidance from IAC, from the country and regional integration officers, from the other programs like CRBS, Super Registration Program, the other programs in the country. So there's a lot of dialogue and also a lot of peer assessment happening together with the international experts. For example, in Asia, we work with India, the regional hub for IAC, Tadam Memorial Cancer Hospital. We work with National Cancer Control Hospital, Cancer Center Japan. So we kind of bring these experts together. We read all the reports from previous IAE missions. We read all their NCCP 5-year strategies and all these, try to really figure out the context and what they want to do. So usually the requests come in a way that, can you do it? And can we get the data immediately by next 3 months, 6 months, 1 year, so that I can talk to the president, talk to the government that we have this. So we also have to manage a lot of expectations, and also trying to have a ground rules for managing the priorities together between the vital strategies, between the international experts, and between the country. So one of the priorities the government, the Ministry of Health want is like, they want good quality data, they want very timely, in fact, they would like to get like weekly data, monthly data if possible, and they would like to really understand what the data is being set so that they can start prevention programs. They can start like, for example, should we build a new cancer hospital or should we invest more in the training of like screening program workers, or like should we invest more on the improvement of the outcomes, or like, so. And in some countries we work, there's not even a national cancer control program, honestly speaking. So they have like some rudimentary cancer control activities. They don't have a 5-year cancer control plan, they don't have a cancer department. So it's like, and some countries, they are also developing countries, but they have been developing very quick in Asia region. So they have really nice hospitals where you can get a lot of like quite advanced treatments. You can get like, for example, like a lot of like really advanced radiation therapies, and like the economy is growing, and but the health information systems are fragmented. You can imagine that each hospital is using a different health information reporting system. So it's also, for the country, it's not only about a matter of technical assistance, it's about like the leadership by the government, the ministry, how they want to lead the initiative, how they want to, where they want to go, and also the coordination. So the coordination between different hospitals, different government departments, between the private sector, and also the increasingly relevant role of the private sector, hospitals, and laboratories. So, and also there's also increasing concern on the data security, data confidentiality, data ownership, like, so always the main priority is how can we get the data most clean, most good quality, like most timely manner, and second is like how do we understand the data, and that is like how we move the data, and fourth is like how can we make sure that the confidentiality, like patient privacy, are like respected. So these are the priorities the government usually see.
Thank you, thank you. So I think that's actually a great time to pause and open up the conversation. If folks have any questions for the panelists, but also welcome you to share any experiences that you may also have on this topic. Yeah.
Hi, so I'm Mathieu Morand from CCAN, City Cancer Challenge, so a lot of known faces here. So we've also been active in collaborating with a lot of organizations here on cancer registries. So a lot of things that you said resonate a lot with what we see. The first is, for us, it's important for a city to do a full comprehensive health system strengthening program, to have some sort of registry in place. And it's no surprise that out of the 3 cities which were shown, Abidjan and Nairobi are cities which are part of the CCAN network, right? And I don't think it's a coincidence. And a lot of, among the programs that we help facilitate, there is almost always a cancer registry quality improvement project. I think Mariam, you've been helping a few of them, in Latin America in particular. And so it's really at the core. Now on top of that, I completely agree with what you said, the cities are asking for more HBCR, more close to real-time data aggregation. There are new use cases which are really emerging. And it's hard, it's very hard to do that. So we've been supporting, in some countries, the setup of HBCR as well. We've been supporting projects which are aggregating data, because if you want to do patient tracking, an HBCR might not even be sufficient, because the patients are treated all across hospitals, right? So you can't track hospitals. So even projects which are looking at aggregating HBCR, which on just few data points so that you can really do patient tracking. And I think the conversations we've been having, and we have with Vital Strategies, is how do we now really bring that very local data that we help building back to either national level or the first population-based cancer registry level. There is so much to do, and I think we're really excited to tighten our collaboration, because from local to national is the only way we go, right? And even the HBCRs, there are so many ways to build them. You're very familiar with the Cali registry. Cali registry from PBCR is very laboratory based. I think they put a lot of reports from pathology labs. They've developed their own AI to sort of like look at the reports. So there are a lot of things we can share also from city to country. So very happy to keep collaborating. It's a topic which is very close to our heart, and I think we need to accelerate because there's so much demand.
Good. Thank you so much, Matthew. And Elsa, we have a question.
Yeah, hello. I have two questions actually. I wonder whether you would want to talk about it. How does the...
Sorry, maybe just introduce yourself first.
Oh, I'm Anuradha from the Indian Express. I'm from India, so I'm a journalist. So how does the WHO plan to address the political resistance and, you know, the diluted language for the UN declaration, especially the health taxes, considering, you know, the global implementation of the cancer control strategy? I mean, we talk about cancer, right? So there is a lot of, I mean, it's all there. So would you like to talk about that? And another question is, you know, there is an increasing burden of cancer in India. And so how does WHO, there are different geographies, there are disparities, and so how is WHO supporting the effort to improve the cancer surveillance and, you know, address challenges because of incomplete data? I mean, because we are very big nations.
So I'd actually, you know, also offer other folks on the panel to answer that question. So I think what I heard was, given you know, given the recent political declaration.
Yeah, because there's a lot of talk about it. I mean, the NCD Alliance and everybody was talking about it in the morning. So I just thought that.
Yeah, I'm very happy to address the question on political declaration. Look, the declaration is a member state negotiated document and declaration. So WHO is only of assistance to provide technical support as much as member states request it, but does not interfere in the text of the declaration. I think what you have heard over and over again is also what is the common opinion knowledge, and it is where WHO is also behind, that it is still an ambitious declaration, that is for the first time an ambition that contains targets, and where also all the cancer targets has been recognized, and what gives also a very good platform for working over the next years. So, and we see the document as such. And again, in terms of the targets, we have said it also very often, targets should not be seen as the ceiling, but it should be seen also as the floor and starting point. So you don't need to stop there. Countries can progress and moving beyond that.
Okay. And I think, Marion, did you want to respond to the previous question as well? And then Eureka, I think you also want to respond.
Yes. Thank you, Matthew, for the intervention. I think we have to be very cautious in terms of immediately the data, to have like real-time data, because in cancer registration and population-based cancer registries, we know from the CI5 call, we have many registries applying, and when we evaluate the data quality, it's not sufficient. So there is a very delicate balance between timeliness and quality. So long-standing population-based cancer registries that have reached the quality. For example, you gave the example of Cali, that has developed really very interesting artificial intelligence and is changing a little bit the paradigm of operation. What they do, what they are able to do, they are not advancing too much. They are like more or less in the European standard, that is that your report is 2 years away from the collection, but you are able, because you have a long-standing history, to make projections. So when you open the web page, you have already the Cali registry projections for this year but the actual data collection with quality checks is 2 years behind. Because really to maintain the quality and the detail, you're speaking of so many types of cancer that, and so many different data sources. So that's a delicate point.
And I'd love to come back to that from an innovation perspective, but before,
I just wanted to comment on the political declaration because I, as some people here in the room, were actually in New York at the UN high-level meeting, and I actually came back quite more positive than I expected this time. So it's my third UN high-level meeting, and I think political declaration, it includes cancer in a different way for the very first time, from different aspects. It's quite sort of, it's even in the preamble, in the operational paragraphs, I mean, it's a mention of cancer and AMR, which is really important. It's a huge threat to cancer treatment and microbial resistance. And I think even though there are some governments who might feel that, well, we don't have to do work and do anything of this, it's just some document, I think quite a lot of countries and governments and also other organizations, private sector partners, civil society organizations, feel that this is something we can gather around. This is something we can talk to our respective governments about and to hold them accountable to work in the same direction, whether they are sort of pro or con this political declaration. So I think just having this political declaration being approved is something that can move cancer control forward in the future. So I'm quite optimistic, even though there is a lot of talk about this is not enough, that we would have liked to see it in a better. I can always want to see things move quicker and forward faster.
Thank you, and I think I appreciated what you said about actually some sense of optimism, coming out of those conversations, because I think what it actually made happen was the responsibility now coming back to the countries and at the country level, and country leaders actually taking on that as an opportunity, not as a challenge, and to think, then when you were talking, I kind of heard data is the rate limiting step for governments who actually want to make investment decisions in this space. And that's a sea change, and I think the demand for the right type of responses, to cancer is coming from patient advocates. I don't know how many patient advocates that, we have in the room, but what a wasted opportunity if people are ready to invest, but they are pausing because they don't have the right data. And I think the other thing, it relates to the conversations that are happening right now with the cuts in government assistance, is the exploration of whether private financing can fill some of these gaps. And the exploration around whether blended financing or pay-for-performance type of investments can also fill some of these gaps. But without data to be able to identify what the right metrics should be for these initiatives, or make sure that the payments are being made on actual real outcome and real results, and to actually see whether it's making a difference. None of that is possible without good data. And and I will share my bias here. I would hate for us to be in 10 years where PEPFAR is in now, where vertical M&E systems were built to measure HIV programs. When that funding halted, the data was no longer available, and all of that data infrastructure disappeared. So let's not have that be the story they tell about cancer investments, in 10 years. So I'll stop at that soapbox. And I think perhaps, Adam, do you want to speak a little bit to data quality and the opportunity of digitization?
Yeah, just to make the point that the timeliness issue and the quality issue is completely dependent on advances in digitalization of cancer surveillance. And in settings where clinical information is captured electronically, where the pathology information and the radiology information is all there. The staging, the reporting is all enabled by that, as not to mention the kind of more advanced, sophisticated AI type stuff. Paper-based records just don't allow that, and so that agenda of making data digital is really what's going to enable that timely and accurate information. And then the other piece is bringing hospital-based registries or bringing PBCRs from different regions in a country together into a national report or into a national synthesis also depends on digitalization. The ability of each registry to use software, CANREG, to standardize the data, code it appropriately, and then compile it at a national level is itself a digitization task. And so for all these reasons, advances in digital infrastructure in countries is happening now and is the only pathway to full, to both completeness, quality, and timeliness.
Hannah, you have a question? Yeah, hi everyone, and thank you very much to the panelists already. My name's Hannah Vaughan-Jones. I'm a journalist and broadcaster, and I'm the host of a podcast called Changing the Ovarian Cancer Story, which is brought to you by the World Ovarian Cancer Coalition. One of the things that we're learning through the podcast is that whilst ovarian cancer is perhaps the most lethal of female cancers, it's also one of the least that people are aware of. And it's very clear from everything you've said so far that improved cancer registries absolutely lead to better policies and patient outcomes. But I'm wondering if there is any evidence yet of a link or any kind of link really between improved cancer registries and public awareness of cancer, such as those kind of cancers that are so very difficult to detect.
Yeah, great. Anyone from the panel, Lillian, or want to speak to that?
Maybe an example, not exactly addressing, but similarly, is Chile has zones with very high incidence of gallbladder cancer. And gallbladder cancer, one of the risk factors is gallbladder stones. So as a public policy, there has been implemented that women with gallbladder stones are offered by the system a cholecystectomy. Women between 35 and 60 years of age. So in the population, that's already somehow people are aware that if you have a gallstone, the system is offering you the cholecystectomy. So that's like an example with a very rare cancer, but it's a very interesting example of how it could drive also awareness. And definitely one of the aspects I have been working a lot with UICC is staging. So I think that if we bring this information closer to the clinicians, it's a bridge between the public health people and the clinical world, we could also make a little bit more change in terms of also the population awareness of importance of knowing at what stage you have a cancer.
Lynn, do you want to share?
Yes, very nice to see people who speak for and spread the knowledge to the patients. Very nice to see. So I'd like to share a couple of examples. So the first example is we have a program in Sri Lanka. So Sri Lanka, when we talk about cancer, they are a middle income country. Before the economic crisis, they have a pretty good economy. And from the National Cancer Program data, what they found is there's a lot of oral cancer happening in the country because of the children's tobacco and retail. So from the registry program data, they found this is a huge issue in the males of the cancer in the male population. So what they did is they rolled out a national oral cancer screening program, where it's not only in the government hospital, but also dental clinics and dental hospital. So it's actually one of the biggest screening programs the Sri Lankan government ended up doing because of the data from the available registry data. So it's still ongoing for like maybe 6, 7, 8 years now. So this is an example. Another example we can give from our program perspective is we are working in Vietnam. So Vietnam has 2 population-based cancer registries, Hanoi City, Ho Chi Minh City. So recently we partnered with Johns Hopkins University so to see the differences, the gender lens, like how they cancer gender lens, like gender perspectives can be brought into like the situation of the cancer registry data. So when we talk about gender, it's not only about the male and female divide, because cancer is interestingly, like some cancers are like male has like higher mortality and like higher burdens, and so it's like a females have like breast cancer, cervical cancer, like all these ovarian cancers, also like lung cancers. You expect males to have more because they smoke. But on the other hand, air pollution and like indoor smoking, females get also a lot of lung cancer. So we partner with Johns Hopkins University to analyze the data from like one of the cancers from both registries as a joint team, and they have like produced some draft reports and findings for this one for the science net. But I think this is the practical examples we can see in the country.
I think there's a great example in Cameroon using data. Yeah.
The Cameroonian government looked at its cancer epidemiology data and identified breast cancer as a high burden of incidence and mortality. And that really informed a number of important policy initiatives, but also public communication strategies. The EPI data led to the development of a new breast cancer screening and treatment protocols in the country. So that's the policy side. But they also engaged in a number of public communication campaigns, and they chose the method of survivor testimonials to do that. And it produced a number of powerful videos and other communication products. Happy to share them with you. But it's an example of that data to policy and also data to public communication that you're asking about.
So thank you so much, everyone. And we're coming towards the end of the session, and I'd love to do a speed round, with the panelists. And I don't think I shared this question with them, so it really is a surprise speed round. But if there was, one thing, that you think as a community we should be focused on to progress cancer registries, what would be the ask? I'll start with you.
It will be an ask because I think to share the good examples, and I think Lillian shared some really good down-to-earth examples of how you've changed the way you treat or screen, or so you have a much more targeted intervention. You have much more targeted intervention because you have the data now. So it's to give this kind of example to actually get people to understand how the importance of good, high-quality data, cancer registries, and the importance of data.
Pushes us into action.
Yes, it does, and it shows really on the ground how it can change the life of women in this case, both in terms of cervical cancer screening and breast cancer.
Great.
Really hard self-examination.
All right.
Well, I was thinking in similar terms. I think that we can highlight also the contribution that different persons or organizations or healthcare workers can do. So the planners need to use the data that are available, even if they are not of good quality, because it's only via the use that you can improve the quality. But also, like the medical community needs to see when they write a clinical note, especially in low and middle income countries, it should hopefully be legible if they are still, and it should be complete, and it should drive some movements around information systems. So I think in the public health arena and health services arena, there is a role of everyone, the pathologist to inform via good reporting, the stakeholders to use the data, the clinical community to think that they are not only noting this patient, but it has also an impact.
Thank you. We'll all get better handwriting. And Lillian?
Yeah, I think it's, if we could start from the grassroots level, that is, we start from the community. Like today we have community health promoters from my country using a program called EGIS to collect data. So they go to the community door to door, ask questions. So depending when it is on cancer, they do a lot of work. So it could be on cancer, it could be on HIV, they have EGIS to collect data. So we collect data and refer the community to go and get screening. So because this problem begins because people are not getting checked. Nobody go to the facility if they're not sick. They only go when the problem has begun, instead of going early enough before the problem begins. So we started from the community where they are getting referred to go to the facility, also demystifying some myths that are there that comes with let's say vaccination of girls with HPV, that they're thinking that when a girl is vaccinated, they're going to be infertile, they're meant to get children. So they talk to them and demystify that and then refer them. They go for vaccination. So we started from the grassroots level where the community is. We need the, because there is the level of the team that understands and the team that do not understand. So we start from where they do not understand by these community health promoters to take data from them. So they key in data from each household, the reasons why they're there. If there is any issue, refer. Like if the particular age, if you're between 10 years, refer for vaccination. If you're a woman, 25 years old, refer for screening. So they keep on going to house, from house to house. And then when they reach the facility, now we also take the data in the facility. So if we can bring in the community health promoters, we start collecting data from our community, from the grassroots level, from the lay medical team. They are lay. They do not know, they're not doctors, but they will speak to them. Then probably we'll be somewhere.
Thank you, Lillian. So if I have to say very concisely, it's two words: investment and innovation. And I have to respond a little bit more. So we have the proof from like US CDC and like the costing tools the various studies have developed together with US CDC and IAC is that it's very cost effective to run a population-based cancer registry. It literally costs like 2 to 4 US cents per inhabitant if you have when you run a population-based cancer registry. And I often talk with ministers like, dear Minister, Your Excellency, it doesn't cost $1 billion to run a good population-based cancer registry. Many African countries, they are in a low-level income bracket, that they have fantastic, very good quality population-based cancer registries running like continuously in a CI5 publication for like many years consistently. So you don't need to be rich. You have to invest in a country yourself, like all the commitments and investment, making sure that the money is allocated, resources are allocated, staff are trained, you are bringing the technical expertise. Also, for the international community, you need to bring investment in a way of innovations, because clearly the paper-based model going like paper to paper is totally outdated, even at developing country studies. So you need innovations like how do we make sure the tools for training are consistent, that can be customized, like applicable, not one country, two country, like you can like customize to the different contexts so that they have like harmonized understanding, the skill set, transferable between south to south, lower south to south, country to country. How do we make sure that we not only look at the reports for the sake of reporting? How do we make sure that the framework of like the big pictures of like monitoring, evaluation, all the support mechanisms in country, within countries, international community, technical expertise, all the governance bodies that are in place to make sure that these registries are sustainable. How do we better digitalize, not only like digitalize the forms, but how do we make sure like meaningful connections between the hospitals, the private and public sector, between the different departments, between the different government sectors, maybe even like use of unique national civil ID systems to make the data trackable and like databases comparable for data matching and quality control, all these steps, and even like to make sure that all these training programs, the treatment outcomes, the survival are meaningful. To have that, we have to make sure that registration systems in the country are well maintained and connected to the cancer registry, so that doctors know, patients know that if I have this cancer, this is my chance of survival, so that ministers, people, division makers, they can look, this particular cancer in this each bracket is like very bad outcome. We really need to change that, very targeted. So investment, innovation.
Thank you so much, Lynn. Thank you everyone for joining, both in the room and online. I think two takeaways I have. One, there's a lot of work happening in this space, and there's a huge opportunity to knit it together and to bring all of the different component parts together. Data can serve as that connective tissue, but it's also the stories and experiences of all of the different actors, in this space. And so, as we can continue to, collaborate to bring all of this together, I think, that's one big takeaway, I have. But then the other takeaway I have around the population-based registries is that it allows us to surface and make visible what was invisible before. And there are too many people in too many countries that we have no idea are dying of cancer. And unless we have some population-based registry, there will always be people we leave out. Just again, personally from a equity perspective, we can't leave folks out of any investments that we want to make in this space. So thank you everyone for joining. Thanks for those on the line. And looking forward to working and collaborating together in some way, shape, or form as we move forward.